Good evening, ladies and gentlemen, and welcome to our Eating Disorder Hope webinar this evening. We're so glad that you could join us for this special presentation featuring our guest, Dr. David Garner, who is the founder and president of the River Center Clinic. Before we get started with our presentation this evening, I'd like to point out a couple things. You will be able to submit questions to Dr. Garner throughout any point of his presentation this evening. You can submit questions through the question pane of your control panel at any point. I will be moderating those questions and will submit them to Dr. Garner to answer. So please do feel free to submit any questions that you might have during Dr. Garner's presentation this evening. And I will now turn it over to Dr. Garner.
Well, thank you very much, Crystal. I really appreciate your invitation and Eating Disorder Hope's invitation to present on psychopharmacology and treating eating disorder patients. I just wanted to, first of all, point out this is not going to really be a clinical lecture on how to go about prescribing a physician. I don't intend on that. But I am concerned about the discrepancy between the research recommendation for treating eating disorder treatments and the practical aspects of this technique. I talked to you this evening about a study that we conducted at the River Center, looking at the frequency of different drugs being prescribed to patients who were first admissions to a treatment facility. So if there are questions, you can certainly ask, put them forward to Crystal, and I'm happy to take those or take them in the presentation. Here's that my slides don't advance, so let's just see how. Hopefully we'll not have to look at this particular slide. So, Crystal, we have a bit of a technical problem. It appears that the webinar, I'm not sure if it's, let's just see something. Oh, good, okay, we have now, but you can see the first slide. It looks like it's, seems to be that things are operating okay. First of all, just a bit of history, words of wisdom from historical sources. That is, obviously, so let food be thy medicine, medicine be thy. And also, famous psychiatrist William Osler, person who takes medicine twice, once for disease and once. Really, just a bit of history, first of all. There have been, 25 years ago, George and his colleagues described a 25-year retrospective chart medication, 96 anorexia patients, 1958 to 62, 60. And what we found was basically that anorexia nervosa, over the period of time, they found that significant increases in the use of antidepressants, 4 to 58%, antipsychotics, 19 versus the last period. This is the previous slide.
Dr. Garner, I'm so sorry to interrupt you, but we are losing your audio. It's cutting in and out. So I'm not sure if you want to switch over to the phone.
Okay.
I apologize.
That's okay. That's not a problem. Do you have a number? What number would you like me to use?
Okay, let me send it to you right now. And for everyone on the line with us, we appreciate your patience, and we should get Dr. Garner switched over so that his audio is nice and clear. Give me one quick second, Dr. Garner. We'll get that over to you.
So Crystal, are you there? Okay.
Dr. Garner.
Yes, I'm here.
So sorry. If you
I'm,
open up,
I'm just going to enter the access code right now.
okay, great.
I followed the instructions. Can you hear me now?
Yes, I think you just need to mute the
I
sound on your computer.
Okay. Now, can you hear me okay?
Yes, we can hear you great. Thank you so much.
That's terrific. Again, I apologize to the audience for this brief interlude. Well, I think the slide that you can see currently has to do with the first study that I'm aware of that was done describing a 25-year retrospective chart review of medication used in 96 anorexia nervosa patients over 3 time periods. And as it's found in this study, there was a dramatic increase in the use of antidepressants from 4 to 58% over the first versus the last period, and antipsychotics from 0 to 19% from the first to the last period. So this trend has also continued in recent years, in more recent years. And you can see from the next slide, Vasily, just a couple of years ago, did an excellent study looking at psychotropic medication for anorexia nervosa, finding that it increased dramatically during the 2 time periods surveyed. And the 2 time periods were actually important, partly because the medications increased. There were nearly twice as many antidepressants in this group in the second time period versus the first. Now, this may have been, there may have been an underestimate in the use of medications because this was not a clinical sample. This was a sample that was obtained from an advertisement for a study of bone density. So it really was not truly a clinical sample. Antidepressants were the first most common, followed by antipsychotics. About 13% of people were on antipsychotics, and the vast majority were atypical antipsychotics. And the rate of antipsychotics, though, doubled from the first time period to the second time period. A clinical study was done a few years before that, which was not an exceptionally well-designed study. It was basically 50 patients of varying diagnoses admitted to an inpatient unit. And it wasn't clear whether or not the medication was assessed just at admission or admission and during the treatment course of treatment. But this study by Gables and Dyson found that 96.7% of the patients were prescribed a psychotropic medication at some point in their admission, and 58% was receiving 2 or more medications. So there's not been a whole lot of research in this area, but studies have shown a pretty dramatic increase in the use of medication over the time frames. So I guess it's not particularly clear. The psychotropic medication for eating disorders is really, at this point, although they're commonly used, it's not really clear who should be getting medications and who should not, at least if you talk to clinical practitioners. And I think in reviewing the research literature, what's most striking is that there is virtually no correspondence between the empirical research on the use of medication and the practice or the use of medications with patients with eating disorders. For bulimia nervosa, there is some evidence that psychopharmacology can be useful, or at least some forms. And however, psychotherapy, from most reviews, is seen as significantly better than medication. Also with medications, the dropout rates are very high. There are very few predictors of responders. And I think almost everyone concludes that the sequence should be psychotherapy before medications. The studies that have been done that have shown that fluoxetine, which has been authorized as used by the FDA for bulimia nervosa, there was a study in the Archives of General Psychiatry in 1992, 8-week trial for bulimia nervosa. It's a well-known study, basically showing that with the higher dosage of fluoxetine, that it was effective over placebo. And then there was another trial in 1995 looking at a 16-week trial starting at 60 milligrams, and it appeared to be well tolerated. But I think the thing that's important is to actually look at the data. The slide's not very clear, but you can see that both with the placebo, which is in the kind of the purple line, as well as the fluoxetine, the binge eating episodes declined pretty dramatically over the course of the 16 weeks of treatment. Now, there was a statistically significant difference between the placebo and the fluoxetine, favoring fluoxetine, but again, it's not as dramatic as one might prefer or hope. The real point of the presentation this evening, though, has to do with anorexia nervosa, and that is that despite the fact that there is virtually no evidence that drug treatments are effective for anorexia nervosa, they're still common. There have been a number of well-known researchers that have done reviews of this area, and Cindy Bulick has concluded that no pharmacological intervention for anorexia nervosa has a significant impact on weight gain or the psychological features of the disorder. Also, Scott Crow has concluded at present there's no convincing evidence of efficacy of any drug treatment for anorexia nervosa in either the acute or the chronic phase of the disorder. Also, Reinblatt concluded with adolescents, no medication induces weight gain or reduced body image concerns sufficiently in underweight phase of anorexia nervosa, nor has been shown to prevent relapse in weight-restored patients enough to support recommending its use in children. So the big argument, at least the argument that I've confronted in presenting these findings, that people are concerned that perhaps we're overlooking efficacy of the medication because the medication may be very effective for comorbid conditions. However, numerous studies have been done showing that antidepressants are no more effective in anorexia nervosa patients with comorbid depression than those who don't have comorbid mood disorders or mood conditions. So there's very little evidence that the comorbidity argument favors the use of pharmacological interventions with anorexia nervosa. One of the reasons for this probably is the nature of starvation symptoms in eating disorders, with anorexia nervosa in particular. Psychiatric symptoms are often secondary to starvation. Everyone on this call most certainly has heard of the Keyes experiment, the Great Starvation Experiment, which took 36 young men and exposed them to semi-starvation conditions during the 1940s, published in 1950. And the reason it's so instructive is because it tells you what anorexia nervosa is not. It tells you really what kinds of symptoms one should logically expect if you simply deprive people of calories and their weight declines over the course of a 6-month period, which is the case in this experiment. Again, these men had no psychiatric disturbances at the beginning of the experiment, were healthy and healthy psychologically and physically. And as everyone should know, they had a number of changes during the course of the experiment, both the acute phase of starvation, which is 6 months, and during the 3-month follow-up period. They were preoccupied with food, collected recipes, cookbooks, menus, had very strange eating habits. They increased their consumption of coffee, tea, and spices, chewed gum, and quite noteworthy, they engaged in binge eating during the course of semi-starvation and during the refeeding phase. But most importantly, as it pertains to this argument about the use of drug treatment in anorexia nervosa, these young men experienced depression, mood swings, anxiety, irritability, anger, psychotic episodes, social withdrawal, decreased sexual interest, and personality changes on psychological tests. So if these men didn't have anorexia nervosa and all they had was starvation, and if that starvation produced these dramatic emotional and social changes, then certainly one has to, the most parsimonious argument for many of the psychological problems that people with eating disorders experience is that they are quite starved. And one needs to separate primary psychiatric disturbances from secondary disturbances that are due to starvation. This next slide is simply a slide that, again, most people should be familiar with, looking at the Minnesota multiphasic personality for these men in the experiment. The open circles show the testing for a man at the beginning of the experiment, and the half-closed circles show after just 10 weeks, and just losing 7% of his body weight. It shows the dramatic difference in his personality. So again, these are not modest changes that result from starvation, but are quite significant, both mood changes and personality changes. So the conclusion that many clinicians erroneously conclude that observed depression, anxiety, and OCD symptoms are primary conditions, weight suppression and caloric restriction, a cause or exacerbate depression, anxiety, and obsessive symptoms. Last year, we published a study of admission psychotropic prescriptions on a clinical sample of anorexia nervosa and bulimia nervosa patients admitted to the River Center Clinic. And just to let you know, this is the River Center Clinic, and it basically has several programs. It has a partial hospitalization program, and it also has a adolescent residential program. So this study was conducted on those two programs. There were no outpatients that were part of this study. Just again, a bit of background, the percentage of patients that have different diagnoses admitted to our treatment facility, about half of them have anorexia nervosa, about a third of them have bulimia nervosa, and then another third have other eating disorder diagnoses. This study was a retrospective chart review based upon a 10-year period with first admissions, and there were admission medications for 738 consecutive first admissions to the adult PHP and the adolescent residential program. It only included anorexia nervosa and bulimia nervosa patients. Males were excluded, BED patients, as well as those with other eating disorder diagnoses. And also cases were excluded where the admission medication was not clear or the information was ambiguous. So the result was that we had 287 anorexia nervosa patients in the study and 214 bulimia nervosa patients, and you can see the distribution of adults versus adolescents in this slide. So for a total of 501 anorexia nervosa or bulimia nervosa patients that were compared. Again, this slide, sorry to bother you at this time of night with so many numbers, but it's just mostly as a mnemonic device for me. This shows the demographic and clinical features of these 500 patients, showing that obviously the adults, quite earth-shattering findings, like the adults were older than the adolescents. The anorexia nervosa patients were thinner than the bulimia nervosa patients, but these are, again, fairly typical picture of the types of patients that are admitted to most partial hospitalization or residential programs in the country. They had basically identical eating attitude test scores in this sample. This is just a list of the medication, the 41 different psychotropic medications that were prescribed for these first admissions. So I'm not going to review every medication on this list, but you can see there were lots of antidepressants, antipsychotics, typically atypical antipsychotics, and also there were a number of mood stabilizing drugs and anxiolytic or sleep medications. And I should point out that the medications, the anxiolytic and sleep, it's not exactly, there's some overlap, I guess I should say, in the medications, because obviously for the antidepressants, we have trazodone, for example. Well, that's an antidepressant, but oftentimes in low dosages, that's prescribed for sleep. And also, as you can see here, for stimulants, there were various stimulants that were prescribed in this sample, but also some other medications that were not really stimulants, but the antihistamine, acetaminophen, which, though was in the cases that we looked at, have been prescribed for the purposes of trying to address attentional problems. So, in conclusion, there were 891 prescribed medications for 429 of the 501 anorexia nervosa and bulimia nervosa patients. So that means there were obviously some people who were not on medication. And the number of antidepressants, there were really close to 90% of those on medication were on antidepressants. 23% of those on medications were on antipsychotics. 22% were those on medications were on mood stabilizers. Almost a third of the patients on medication were on anxiolytic or sleep medication. 9% were on stimulants. So now turning to the prescriptions by diagnosis. So you can see here that 83.6% of the anorexia nervosa patients were on some form of psychotropic medication, which is not really that much less. It was not significant, the difference between the anorexia nervosa patients on psychotropics and the bulimia nervosa patients, which is 88%. Turning to adults versus adolescents, you can see here in this slide that almost 90% of the adults were on a psychotropic medication, and 78% of the adolescents. And that was statistically significant, the difference. So there were more adults on medication than adolescents, but still a significant number, about more than 3/4 of the adolescents were on a psychotropic medication. In this slide is the percentage of patients on psychotropic medications by diagnosis, and the red bar is anorexia nervosa, and the yellow is bulimia nervosa. And this is patients on 2 or more medications, so about half of the patients were on more than one medication. You can see in the next panel, about a quarter of the anorexia nervosa patients were on 3 or more medications, compared to 28% of the bulimia nervosa patients, and 10% to 12% of both diagnostic groups were on 4 or more medications. The percent of adults versus adolescents, this again confirms the earlier slide that's presented, and that is that almost 56% of the anorexia nervosa patients were on 2 or more medications versus 30% of the bulimia nervosa patients. A third of the anorexia nervosa patients on 3 or more versus 12% of the bulimia nervosa patients, and 14.5% of anorexia nervosa patients on 4 or more medications, compared to about 5%. The medications of those on medication, so of the 429 patients on medication, almost 90% were on antidepressants, 23% on antipsychotics. You can see the 22% on mood stabilizers, and a little less than a third on sleep or anxiolytic medication, and less than 10% on stimulants. So this is comparing anorexia nervosa and bulimia nervosa. Again, the anorexia nervosa in yellow and bulimia nervosa in red. Again, this just shows the preponderance of medications were antidepressants, but there really weren't any significant differences between the diagnostic groups in antidepressants, antipsychotics, or mood stabilizers. There were differences in anxiolytic or sleep, with more anorexia nervosa patients being on anxiolytic or sleep medications and fewer being on stimulants. Medications, adults versus adolescents. Again, the whopping majority of the patients were on antidepressants of both diagnostic groups. There were no differences between antidepressants or antipsychotics between diagnostic groups, but there were differences with more anorexia nervosa patients on mood stabilizers and anxiolytic or sleep medications, and there was no difference on stimulants. So I guess the summary from this study was that the study really confirms that prescriptions of psychotropic medications for those with eating disorders is widespread in clinical practice, and this practice is discrepant with the published evidence-based guidelines. And I guess I'd be interested in, at this point, Crystal, if there are any questions. I mean, I have more information, but I guess I'd be interested in people's thoughts about whether this, I guess, conforms to other people's experiences with the frequency of medications being prescribed for anorexia nervosa in particular. And remember that there are, to my knowledge, no controlled studies showing that people with anorexia nervosa benefit from being on psychotropic medication. There, of course, people from a clinical point of view state that these medications may be effective, and I'm certainly not disputing that they may be effective in some instances. But I guess the level of medications prescribed for clinical samples stands in stark contrast to the published evidence on their efficacy, which is, I think, a concern, because, of course, medications may be effective, but they also have significant side effects or byproducts, particularly in frail patients who are undernourished, underweight, and are already at risk for cardiovascular symptoms or cardiac symptoms, also at risk for liver consequences to being on medications. So the risks associated with being on medications are not insignificant, and again, the benefits do not seem to be evident in the published literature. Any questions at this point?
Dr. Garner, we do have an attendee who's wondering if you are knowledgeable of any statistics on individuals who stop psychotropics completely after weight gain or in recovery.
I don't know of any. There were some studies of whether or not fluoxetine, for example, prevented relapse in anorexia nervosa, and I think the uncontrolled trial suggested that fluoxetine may be, Walter Kay, I believe, did a study showing that fluoxetine may be beneficial in preventing relapse. But then a very careful study was done by Tim Walsh, showing that actually that uncontrolled finding was not confirmed in a controlled drug trial. So that certainly that was with anorexia nervosa. I think that things get muddled because it oftentimes, at least with anorexia nervosa, after patients are weight restored, the psychological symptoms that are secondary to starvation, those do not dissipate immediately. Oftentimes they may continue for a period of time, just like they continued in the key starvation study in these normal young men who are refed. They continued to experience psychological symptoms and actually binge eating symptoms and other eating problems and food preoccupations. They tended to continue to experience these symptoms quite a bit after they had been fully weight restored. So in anorexia nervosa, one could speculate that even once people are weight restored, that psychological symptoms that are secondary to starvation will persist. So certainly when people are weight restored, and after a period of time has taken place, I'm assuming that that it would be beneficial for people to have a drug holiday. I think it's always probably a good idea for drug holidays to be entertained as part of practice. So, but I don't know of any statistics showing that once people discontinue the medication, what the impact or the effects are, at least in a controlled research. Does that answer the question?
Yes, thank you, Dr. Garner. We have another question from one of our attendees who's wondering your thoughts about treatment of comorbid depression and anxiety that may have preceded eating disorder behaviors.
Right. Well, again, it's an excellent question. It's probably the most, well, certainly the question when we submitted this paper for review was one of the hottest topics for controversial topics during the review process. And I think that I don't know of a study where comorbid conditions prior to the onset of the eating disorder have been assessed in a careful way, and then the person has been exposed to drug treatment. So I don't know of a study that addresses that specific question. It's a good question, but I guess I get a bit the problem with trying to do proper research on this topic is that if somebody had premorbid depression and then they developed an eating disorder, well, now they have premorbid depression, but then they could have secondary depression related to being starved. So what is it that we're actually observing? What is the genesis and what is the origin of this depression? Is it due to the premorbid condition? Has the premorbid condition continued to operate with the person once they become starved? Maybe the depression, the premorbid depression has actually dissipated and has been replaced by depression secondary to starvation. And it gets very confusing. So, but I don't know, and it's a good study to do. One should really look at a group of patients that have premorbid depression and expose that group to a treatment trial versus patients that do not have premorbid depression. Now, Cindy Bulick's review of the literature, though, has suggested that antidepressants for anorexia nervosa don't seem to show any statistically significant impact upon either weight gain or or premorbid conditions, depression. Now, she didn't do this careful study where she just ferreted out the people who had premorbid depression versus not, but depression didn't improve in these patients that were on drugs. So, at least with anorexia nervosa, there's been 50 years of research that has shown a pretty dramatic increase in the use of medications, particularly antidepressants. And the argument has been that maybe this will benefit people who have premorbid depression, but I just think there isn't much evidence to support this. And in this area, I'm a little concerned as a scientist. Again, one of the basic axioms of science is that we assume that the null hypothesis exists until it's disproven. In other words, we assume no differences in groups until it's disproven. So it's really the onus is on people who would suggest that there is a benefit to demonstrate that before it's actually implemented in clinical practice. The arguments that I've heard are that basically we should assume, based upon either clinical evidence or conjecture, that pharmacological interventions are beneficial for premorbid conditions until that fact is disproven. And that's kind of standing science on its head. So I really feel like at this point, we have moved forward in a very aggressive way with treating patients, particularly with antidepressants. We've been very aggressive, but at this point, the onus really is upon researchers and clinicians to assume that there is no effect until we demonstrate it. Make sense?
Yes, thank you so much.
One of the other things before we get to the next question, I guess, bearing upon that particular question, I think the thing that also should be taken into account is that the effects of antidepressants in depression are somewhat more modest than drug companies might suggest. there was an excellent study a few years ago looking at selective publication of antidepressant trials and its influence upon apparent efficacy, which is shown in this slide. So a study by Turner and his colleagues, which is published in the New England Journal of Medicine. And what this study actually showed was, again, sorry for how dense this slide is, but among the 74 FDA-registered studies, 31%, accounting for to almost 3,500 study participants, were not published. 37 studies viewed by the FDA as having positive results were published. One study viewed as positive was not published. So studies viewed by the FDA as having negative or questionable results were, with 3 exceptions, either not published, there's 22 studies, or published in a way that, in the author's opinion, conveyed a positive outcome. So essentially what this means is that the research that we are exposed to really relates to the selective publication of positive findings. That negative findings tend to not be published as often. And so if you take all of the positive findings and the negative findings from published and unpublished studies into account, the degree of efficacy that has been demonstrated in the so-called positive trials is dramatically attenuated and reduced when one takes into account the unpublished studies. So that this is, again, a rather confusing slide, but if you just take a look at it for a moment, you can see that all of there's on the left-hand side of the slide, there's positive findings, questionable findings, and negative findings. And then in each one of the horizontal axes, beside positive, questionable, and negative, you can see the number of studies I believe that's the number of the number of studies where the positive findings have been published and agree with the FDA's conclusion. So most positive studies agree with the FDA's conclusion, and only one study was not published with positive findings. But if you take a look down in the very lower part under negative findings, you can see the negative finding studies, the majority of these studies were not published. So I think I don't want to be hypercritical of drug companies, but you can see just from a fairness point of view, I don't think that clinicians who are using published studies to try and gauge their clinical practice are actually seeing the full picture. They're not seeing the negative findings, which are being not withheld, but just simply aren't being published. And I think that it should be incumbent upon the FDA to give greater, require that studies with negative findings are published along with those with positive findings, despite the pressures that might exist from various moneyed interests. Next question.
Thank you for answering that, Dr. Garner. We do have a couple other questions. One of our participants is wondering if stimulants were prescribed for coexisting disorder of ADHD or to address something else.
It's a brilliant question. First of all, I guess I have always wondered that if one of the side effects of stimulants was that they caused rapid weight gain, how many eating disorder patients do you think would have attentional problems? I don't think the drugs that do cause weight gain, like Depakote or other drugs that cause weight gain, they seem to be less popular. So my concern, particularly with the frequency of stimulants being prescribed for bulimia nervosa, that I'm concerned about the fact that patients are aware of the fact that these drugs are appetite suppressants, and they could be used in the interest of the eating disorder psychopathology. I also think that somebody that's being hospitalized or is in partial hospitalization or residential treatment for a serious eating disorder, in most instances, I don't think reading attention or attentional issues need to be the primary focus at this point. So I guess we're quite concerned. I think our psychiatrists and our physicians at the River Center Clinic tend to really be fairly aggressive at helping people get off medications for a drug holiday, unless there is a truly compelling reason for them being on them. And I think the most noteworthy instance would be people on stimulants. And stimulants have serious risks associated, particularly in emaciated patients. And I think that again, most of the patients who are on these medications understand their effects upon appetite, and I think certainly a strong suspicion should be cast that the medications are being used in some sense to carry out the psychopathology that exists with these patients. Now, again, I realize there's some people out there that are enthusiastic about stimulants in the treatment of eating disorders, and again, I don't know of any careful research that's looked at this. I just think these are not benign medications. Attentional issues are probably not the most significant factors that are operating with most patients. There may be a few patients who need medications to enhance attention in order to benefit from psychotherapy, but my suspicion is that when you scratch just below the surface, that it's pretty likely that most of these patients it's not lost upon them that these medications are appetite suppressants, or many of them are, certainly the amphetamines.
Thank you, Dr. Garner. Another question for you. If you have any thoughts about Vyvanse for BED?
Well, this just really relates to personal opinion, pretty much, as opposed to, and that is that there may be some role for Vyvanse, but again, Vyvanse is a stimulant, and so there have been studies looking at stimulants in bulimia nervosa, and I think that I wonder if there shouldn't be a sequence of kind of in the thought process and whether or not this medication should be used. Remember, as I showed you in an earlier slide, that if you take normal young men and simply get them to lose weight, that many of them will engage in binge eating. So the most parsimonious explanation for binge eating in general is related to dietary restriction and weight suppression. Now, not all binge eating patients have had weight suppression, but if you carefully look at their histories, most of them have had periods where they have restricted their food intake. Not all of them, but most of them have. If the patient has engaged in a pattern or history of weight suppression, or is currently in a weight suppression phase, or in the phase after weight suppression, which would have to do with rapid weight gain, then I think one should consider that the least harmful and most benign and most effective medication with the fewest side effects may be food. So if patients are exposed to regular food intake over a period of time, again, a period of time that approximates the period of time that the normal starvation volunteers in the KEY study took to overcome their binge eating, if the person is still binge eating at that point, then it may be useful to consider it. But again, the magnitude of the reductions in binge eating with Vyvanse are not as impressive as might be characterized in the ads for the medication. So it's the magnitude of binge eating reduction is, I think, unimpressive. Number one. Number two, it's not without side effects. Number three, again, most parsimonious explanation is weight suppression and dietary restriction. But ruling those out, if one rules out all of those, then, and particularly people that have extraordinary levels of binge eating and just uncontrollable binge eating, perhaps Vyvanse might be useful as an initial drug choice to try and reduce the frequency of this very distressing, disturbing symptom. But again, this is my opinion. It's not a clinical opinion. It's based upon my understanding of the research on Vyvanse. Again, modest effects, and have patients been carefully ruled out who are suffering from weight suppression or severe dietary restriction, which could be precipitating their binge eating episodes.
Thank you, Dr. Garner. Another question for you. How would you approach the eating disorder if the ADHD diagnosis came first?
I'm sorry, which diagnosis came first?
The ADHD diagnosis?
Okay, yes. Well, okay, that's, I guess, the way that I guess, again, I don't know of any careful research that's been done on this, and I'm really, commenting on the research as opposed to, I'm not a psychiatrist, I'm not a clinician, I'm basically a researcher, and so I don't want to offer clinical advice, but I guess from a theoretical point of view, the concern that I have is that if somebody comes into treatment with a serious eating disorder, then I guess the attentional issues by comparison seem to be less urgent. I guess I'd be really keen to see the eating disorder addressed first in the sequence of treatment choices, treatment objectives to try and treat the eating disorder. And if after the person has recovered from their eating disorder and now they're heading back to college and they're experiencing some attentional difficulties, well, then that might be the most appropriate timing for the initiation of reinitiation of the stimulant. Again, I don't know if the audience is worried about this, but I guess I'm worried about the confounding factor here of the eating disorder psychopathology, a medication that suppresses appetite, and again, I think our clinicians at the clinic almost always ask patients, listen, if a new research study just came out and just showed that Adderall causes, it's fine, you can take it and your attention will be much better. But the only consequence is you'll just be gaining 10 pounds more. We'll just have to settle at a goal weight of 10 pounds more. I don't think that any of our clinicians have found a patient yet who said, gee, I would just trade my improved attention for 10 pounds, no problem. I don't think they've ever experienced that. So that's kind of a test. I mean, if somebody's really complaining of serious attentional problems and those predated the eating disorder, and it has nothing, the medication has nothing to do with weight, attempts to control weight, then I guess it might be reasonable. But exactly how is the attentional problems that predated eating disorder, how are they interfering with treatment? Are they really interfering with treatment? And that's the most important factor that has most serious factor that is impinging upon their life at this point. And that is they have a serious eating disorder that's potentially fatal, certainly debilitating, and I don't think that again, I not to minimize the importance of attentional problems, but it may be something that's best left until the eating disorder is completely resolved. Now, it may be that there are cases where the attentional problems are truly interfering with the process of psychotherapy, and obviously one must consider that. But as I mentioned to you, the kind of the litmus test that our clinicians use is to really find out, is there any evidence that the medication is being used to carry out the psychopathology of eating disorder? If that's the case, then it's probably not the best thing for patients to be utilizing.
Thank you, Dr. Garner. We have one more question here for you. Is there a certain dosage of fluoxetine that was prescribed for anorexia nervosa?
I'm sorry, can you repeat that?
Sure. Was there a certain dosage of fluoxetine that was prescribed for anorexia nervosa?
Yeah, that's a great question. When we took a look at the fluoxetine levels in the patients that were prescribed fluoxetine, the most striking, I guess, factor in our study at least was that the medication dosage was in most cases well below the 60 to 80 milligrams that has been shown to be effective for bulimia nervosa. So for the bulimia nervosa patients, they were on pretty low dosages. And so that a greater proportion of the bulimia nervosa patients were on fluoxetine, first of all. That was 34% versus 23%. That was slightly significant for significant. But based upon the findings that higher dosages of fluoxetine are more effective than bulimia nervosa, we found a trend for a greater proportion of bulimia nervosa patients versus anorexia nervosa receiving the 60 milligrams or more. And that was so 29% of the bulimia nervosa patients were receiving 60 milligrams per day or more versus 15% of anorexia nervosa. And that was a trend, not significant. But it's important to point out that the dosage was inadequate for 70% of the bulimia nervosa patients. So even if one assumes that fluoxetine has some merit for bulimia nervosa, which it does, then most of our patients, when they came into treatment, were receiving an inadequate dosage. So it's a good question. It's a good question. It was a question one of the reviewers asked in this paper, and we went back and took a look at the dosage level, and it was woefully inadequate for bulimia nervosa. And again, for anorexia nervosa, it seems to be misplaced in general because there's no study showing any effect with anorexia nervosa whatsoever in terms of its outcome or its effect upon depression levels.
Great, thank you so much. And we actually have one last question, if that's okay. One of our attendees is wondering if there's any research done on marijuana and eating disorders.
That's a great ultimate question here. Is this question from Colorado?
I'm not sure.
No, just kidding. No, listen, I don't know of any research on. There may be research. I'm just not aware of it. I'm not aware of. There was some early research looking at THC as a medication to promote appetite, increase in eating in anorexia nervosa. That's pretty old research. I don't know of anything that's any newer research on this topic. Now, again, I just may not know about it, but I have not seen it. I do know that there's a long history of medication. So antihistamines, for example, were prescribed many years ago for anorexia nervosa. Chlorpromazine was prescribed for anorexia nervosa. Insulin was prescribed for anorexia nervosa, all with the aim to increase appetite in these patients. But it's important to understand that it's truly misguided to think that anorexia nervosa patients are lacking hunger. They feel extraordinary appetite and hunger, but they override that with the mental or the cognitive imperatives to not eat. So it would seem to me that the use of a medication that would increase appetite would only increase the conflict that patients are experiencing, the distress they're experiencing, because they're already suppressing their urge to eat because of the imperatives to not eat. And so now you're going to throw on top of that a medication that increases their appetite. So I don't know of any studies, but I think that the logic behind it is probably misguided, unless there's some other line of logic that I'm missing, which may be that it might improve their general orientation toward life, or they might experience relaxation. There may be other reasons for why marijuana use would be effective. But again, my understanding of it, along with other medications, have been implemented that increased appetite is under the misconception of anorexia nervosa as being due to a lack of appetite.
Thank you so much, Dr. Garner. We really appreciate your time and just you being here and sharing your expertise and knowledge on this very interesting topic. So thank you so much for this excellent presentation. We really appreciate it.
Well, I also really want to thank the audience, and I want to thank, I mean, it's at least on the East Coast, it's late, so I'm honored to have been able to present to people and the people there to listen to it. And I appreciate the excellent questions. And my email was on the first slide. If there are any questions that anybody has, you can see my email address here. You can certainly email me questions. Or if you'd like a copy of this published paper, simply email me and I'd be happy to send it to you.
Thank you so much. And can you also just briefly give us some information about the River Center Clinic and where individuals could find out more information about that as well?
Okay. Yeah, the River Center Clinic is located just outside of Toledo, Ohio. You can go to the website, which is river-center.org, and it's a small treatment center. It is not a chain. It's a small treatment center that offers specialized enhanced cognitive behavioral treatment with an excellent nutritional rehabilitation program. And we're small, about 10 adult patients in partial hospitalization, and about 10, we have capacity for about 10 adolescents in our residential program. And of course, we have outpatient treatment. If you have questions, though, you can either email me or go to river-center.org, and the treatment programs that we offer are well explained there.
Wonderful. Thank you so much again, Dr. Garner, for your time and for this great presentation. And thank you to all our attendees for joining us this evening. We hope you enjoyed the presentation as well. And for more information about our upcoming webinars, I would encourage you to visit us at eatingdisorderhope.com. On the side rail of our homepage, we have a link to our webinars, and we will also have a recording available of Dr. Garner's presentation this evening in case you'd like to go back and listen to it again. So on behalf of Eating Disorder Hope and our presenter, Dr. Garner of the River Center Clinic, we thank you for your time and hope you have a wonderful evening. Take care, everyone.
Thank you. Bye.